Most often, 4 stages of colon cancer are identified. At the first stage, the tumor is located only in the superficial layers of the intestinal wall. Most often, this is what's called cancer in a polyp, or more widespread tumors, but they also do not extend beyond the wall of the intestine. The second stage of colon cancer is when the tumor has grown a bit deeper into the intestinal wall, reaching the muscle layer, the main layer of the intestinal wall, but there are still no metastases in the lymph nodes. In other words, the tumor has grown as a mass, a nodule in the intestinal wall, and for now, it remains as this nodule. The third stage of colon cancer means that, in addition to the main tumor nodule, there are already offshoots of the tumor, but so far they are only at a short distance from the tumor, located in the lymph nodes. These are called lymphogenic metastases. This means that cancer cells are able to break away from the primary tumor and spread some distance from the original tumor site. Specifically, they travel through the lymphatic vessels to the lymph nodes, where tumor growth begins separately. And the fourth stage of the disease is when those same cancer cells start to spread through the bloodstream, allowing them to reach any organ in the body. Most often, the first organs affected by the spread of the tumor are the liver and lungs. That's why, when diagnosing colon cancer and determining its stage, it's very important to perform the following examinations. The first is a colonoscopy. This is done to take a biopsy from the tumor and to determine whether there are any accompanying polyps, or sometimes even tumors located in another part of the colon. The second is a CT scan of the chest and abdominal organs with contrast, because during these studies we closely examine the lungs, liver, and other abdominal organs to see whether there are any distant metastases. We can also detect lymphogenic metastases, meaning enlarged lymph nodes in the mesentery of the colon. And if the tumor is located in the pelvis, in the rectum, then an additional MRI of the pelvic organs is performed, also with contrast, following a special protocol. These are not standard pelvic organ studies, but a specially developed protocol to determine the extent of rectal cancer. And based on at least these 3 diagnostic methods, a preliminary decision can already be made about how and in what order the treatment of colon cancer will be carried out. Since the main method of treating colon cancer is surgery, the outcome of the treatment actually depends on how effective this operation is. The surgery itself involves not only removing the section of the intestinal tube where the tumor has formed, but also the surrounding fatty tissue, known as the mesentery. This is the structure that anchors the colon inside the abdominal cavity and holds it in place. And within the mesentery run the blood vessels and nerves from the main trunks directly to the wall of the intestine. And it is precisely along the paths of these blood vessels and nerves, like little roads or conduits, that tumor cells most often spread. That's why the surgeon's task is to remove not only the primary tumor site, but also as many lymph nodes as possible associated with that segment of the colon, in order to eliminate lymphatic metastases as well. Unfortunately, at the current stage of medical and diagnostic development, the doctors who perform CT scans and interpret their results cannot always guarantee that they are accurately assessing the condition of the lymph nodes, whether or not they contain tumor cells. That's why the stage determined by CT scans in cases of colon cancer is referred to as the clinical stage. This may not be the exact stage. It can change one way or the other after receiving the results from the most accurate histological examination following surgery. That's why it's the surgeon's job to do everything possible, using all their skills, to remove the tumor in all its forms. For stage 2 and 3 colon cancer, it is necessary to perform lymph node dissection, which means removing not only a section of the intestinal tract, but also the surrounding fatty tissue along with the lymph nodes. These techniques were developed in Japan and spread mostly throughout the eastern half of Eurasia, but since the 2000s, they have also been used in Russia. I learned these techniques from Professor Tsarkov, who brought them from Japan, modified them, and adapted them for Russian patients, and I actively use them in my own practice. For all patients with stage 2, 3, and even 4 colorectal cancer, I perform tumor removal along with extended lymph node dissection to ensure the complete removal of cancer cells from both the primary tumor and the lymph nodes.